first to Mike for that very kind introduction, and also to everybody here and to Tova for this invitation to talk. And we really appreciate this opportunity to share some of this information. So what I would like to do today is actually talk a little bit, it's on the side, sorry, talk a little bit about the endocrine aspects. And I'm going to focus a little bit more on adults, but a lot of this is actually relevant to pediatrics. Dr. Collins did a very nice job of introducing many of these aspects of the McCune-Albrights that we worry about. But I want to go into a little bit more detail and talk to you a little bit about, as an example, one of the patients that we've seen, because I think that's a good sort of context to think about what we need to consider. Okay, so I do have some research disclosures. None of them have any conflicts for this particular presentation. And I like to start with this slide. This is actually my research team. We do more than fibrous dysplasia. We do a number of different rare diseases, but we've been very fortunate to have support from the NIH as well as from a number of really wonderful collaborators. All right. So what I want to do today is really start with a hypothetical patient. This is actually based on a patient that I've seen in our clinic. Have a brief discussion about some of the endocrine considerations. Because of the nature of this talk and this audience, it's going to be necessarily on the higher level. And then we'll have some time for questions and answers. And I will talk that, the purpose of this is to give you a general overview. If you have specific questions, we can talk about them later on. It's really important that you discuss with your doctor because of all of the specifics for each individual. Okay, so here's an example of a patient. This was a 40-year-old woman, former school teacher, a long history of pain that's been going on with her fibrous dysplasia. And she was originally diagnosed with fibrous dysplasia affecting the left side of her body and also some craniofacial lesions. Interestingly, she has no birthmarks. She was diagnosed as a child with fibrous dysplasia, has been doing well, has a family, generally no concerns. And over the past 10 years has noted this really significant increase in pain. She has chronic pain. And recently has felt that that her forehead and her left cheek are actually getting much more prominent. Craniofacial fibrous dysplasia, this has been a major feature for her. She has changes in her teeth, she has cavities, she has pretty persistent headaches. And her labs are notable for a normal calcium and phosphate and an elevated alkaline phosphatase level, sort of in the 1000s. What has helped her really is that, in terms of her management, is that she was originally diagnosed with fibrous dysplasia, so she knew about that. She's been very fortunate to have a multidisciplinary care team with ear, eye, endo, ortho, pain, dental. Everybody's sort of aware about what's been going on. And for her, the biggest challenge is really recognizing this balance between living life and managing the disease. So, as Dr. Collins has mentioned earlier, McCune-Albright syndrome affects many organs. I'm not going to go through this in a lot of detail, except to point out the middle part, the endocrinopathies, which has the pituitary lesions, growth hormone and acromegaly, early puberty, thyroid hyperactivity, as well as this increase in steroid production and Cushing's syndrome. Many of these presentations that you see in McCune-Albright's are endocrine in nature. And this becomes important because when we think about the fibrous dysplasia of the bone that does occur in McCune-Albright's, this is actually one of the hallmarks that is present, but also a useful sort of harbinger of anything else that's going on. It allows you to try to assess if there are particular things that are occurring within the endocrine system. So when we think about McCune-Albright's, we know that many of those endocrine aspects present early in life. These are often definitively managed early on. These include things like the growth hormone hypersecretion, so there might be pituitary function, and you can either treat them medically, typically, very rarely is a surgical intervention actually utilized. But one of these things that is useful to keep in mind is that sometimes these can present a little bit later in life. And they may require medication and different types of medical management. Hyperthyroidism, this may require thyroid hormone replacement after there's been a surgical resection of the thyroid. The adrenal tumors and the Cushing syndromes, this may require lifelong steroids and different types of steroid replacement. And obviously the fibrous dysplasia of the bone. And this can be very tricky to manage sometimes because of the calcium and phosphate metabolism, as Dr. Collins mentioned, but also because of the fractures, the deformities, and the significant pain that can occur. So when we talk about the fibrous dysplasia regrowth in adults, typically we know that many of the fibrous dysplasia lesions will stabilize by about the third decade. And anytime you start seeing somebody who's a little bit on the older side and saying, okay, well, it feels like things are getting bigger or that a previously stable lesion is starting to grow, that's when we start thinking about hormone reevaluation. So the main one, as Dr. Collins has mentioned, is the screening for the growth hormone and the IGF-1 levels, because sometimes this can be a little bit, for some reason, a little bit later presentation of the McCune-Albrights. We also recommend things like screening for the thyroid hormone levels and just imaging, just to make sure that there isn't something else that is causing or stimulating the fibrous dysplasia lesion growth. And sometimes these can be simple things like a local infection, what we call osteomyelitis, or an infection that affects the bone. And very, very, very rarely, and reported in literature, but not often seen, is a conversion to malignancy. And so we do worry that patients with fibrous dysplasia might actually turn into something like an osteosarcoma. So this becomes a very significant and important aspect where the fibrous dysplasia, changes in the nature of the fibrous dysplasia lesion, should trigger additional assessments. So I want to step back to our patient for a moment because I think this is where we started thinking about this. As I mentioned, she's 40 and has started to report what she thinks is actually regrowth of some of the lesions in her craniofacial fibrous dysplasia. And it turns out that her IGF-1 level was elevated. So on our assay, the normal level is about 150. Hers was about 170. It's not that high, but it was probably enough for us to trigger additional assessments, and so we did look at her growth hormone levels. Her other hormones appeared to be okay. And when we went back and looked at her CT imaging over time, it did show that there was expansion of the lesions. There wasn't any complications. We didn't identify anything else that we were worried about. And so what we did do was we started her on a medication called octreotide. This is a once-a-month medication. It suppressed her growth hormone hypersecretion, and so her IGF-1 came down. And her alkaline phosphatase did come down a little bit, but not completely down to normal, so it's still in the 1,000 range. And so what we're doing for her is we're continuing to try to manage this, to try to keep this down. Interestingly, her extra growth did slow down after we had suppressed everything, and so she's actually done pretty well from that standpoint.
What was the medication that she started on?
It's called octreotide LAR. This is a long-acting octreotide. It's a medication that helps suppress the growth hormone production. So, there are a number of different types of these medications now, and so depending on the situation, we choose different ones. So, as I mentioned, I think a key thing about the fibrous dysplasia is really thinking about the bone health. So we think about these fibrous dysplasia lesions and how they're important, and they tend to stabilize by the third decade of life. But one of the things to be aware is that fractures continue to occur just because fibrous dysplasia itself is weaker than normal. And not only do we think about fibrous dysplasia, but patients with fibrous dysplasia and McCune-Albrights are still susceptible to the same common conditions that all of us are susceptible to. And these are things like osteoporosis. They may require medications to manage the osteoporosis and the bone thinning, especially as patients get older, and arthritis, which can be accelerated sometimes due to the deformities as well as changes in the bone. It's really important for things like hearing and vision screening to continue, and dental health can also degrade over time, especially if the bone lesions in the jaw are around the teeth. So you can sometimes have difficulty with integration with implants and tooth fragility. And so a lot of this, as you can see, sort of comes all together related to the fibrous dysplasia. So I want to bring up a couple of other topics which I think are really important. One is women with FD and MAS. So gynecologic changes are common in women with MAS. And as many of you have heard from the earlier talk, this can be things like irregular periods or abnormal uterine bleeding, infertility, ovarian cysts, and sometimes primary ovarian insufficiency. And these are components that's really important for an OBGYN to be aware of because this is part of the picture for McCune-Albright's. It's also important to know that despite the fact that some women may have these irregular periods, they are still fertile. It is possible to have spontaneous pregnancy, the use of appropriate contraception, if that's desired, that's actually really important to do. And in the setting of the changes of the menstrual cycles, things that affect bone pain, like the fibrous dysplasia-related bone pain, those can change over the course of the cycle. And there's no clear changes in terms of bone outcomes or pregnancy outcomes for women with the fibrous dysplasia and Albright's. We do have sort of a separate thing where we are concerned, if there's fibrous dysplasia lesions within the pelvis, a natural birth delivery, you do have to be extremely careful about. So those types of things are very useful to know. We do also recommend, that pregnancies are planned so that we can sort of help with all of that type of guidance. But aside from that, there are no really significant problems or changes in terms of bone or pregnancy outcomes. And for women with the fibrous dysplasia and McCune-Albright's, sometimes oral contraceptives can be very helpful for regulating the cycles and actually for control of some of these symptoms, including the pain. The other aspect that is important to keep in mind is that we do recommend cancer screening for patients with fibrous dysplasia and McCune-Albright syndrome. So GNAS mutations, the mutations that cause fibrous dysplasia and McCune-Albright's, are found in other types of cancers separate from the FDN-MAS. Okay, so these include thyroid and pancreas and breast. This gene, we do know, is really important for controlling cell replication. And there are studies that suggest that patients with FDN-MAS may have a slightly higher risk of certain types of cancer, specifically in thyroid, cervical breast, prostate, and melanoma. This association is not particularly strong in some senses, but it is important for everybody to know about. And so because of this, we do recommend that everybody make sure that they follow the recommended screening procedures. And so there is also this other aspect that there's this potential transformation of fibrous dysplasia bone lesions into things like osteosarcoma or chondrosarcoma. Again, this is extremely rare. It's at the level of case reports where there are a few people who have been reported to have this. We're not 100% sure about what the mechanism is or what the connections are. But again, if something is suddenly changing, if pain is suddenly out of control and very different, it is very important that this just be checked for and thought about. So we generally recommend that age-appropriate cancer screening should be done on time and not missed. So the last thing that I really want to touch upon is this important aspect about McCune-Albright's patients and endocrinology and surgical planning. So anytime a surgery is planned, make sure you involve your medical team. And this is particularly important from an endocrine standpoint, because if you have had a prior history of pituitary surgery or a history of sodium imbalance, potentially from either pituitary lesions or things that you have had done. So that, for example, if there's a patient who happens to be on a medicine called desmopressin, or you've been told to watch your salt intake and things like that, this is really important for the surgical team to know. And then the other group that we really want to emphasize are patients who are on steroid replacement. So if they've had adrenal surgery in the past and they're on stress dose steroids or they're on hydrocortisone or some sort of steroid replacement, make sure your endocrine team is aware that you're going for surgery and that your surgical team knows that you are on these medications. Because these types of medications really need to be adjusted in the setting of any type of surgery so that things don't inadvertently happen. And I guess one of them, which I didn't actually include on here, is actually if you have also a lot of calcium or phosphate issues in terms of trying to maintain normal calcium levels or phosphate levels, your surgical team should also know about that too. All right, so as I mentioned with my patient, the comprehensive care team is actually really important. And so I just want to briefly touch upon this because I think, in this day and age with telemedicine and different types of options for getting medical care, it is important to make sure that everybody is integrated together. And so having a good primary care physician, as well as an endocrinologist or metabolic bone specialist, somebody in endocrinology or rheumatology, as well as your surgeons and your nephrologist and mental health specialists, all of these people need to come together to really give you the optimal care. And in many situations, it's really important to discuss these types of treatments, not only to make sure that everybody knows what everybody else is recommending, but also to make sure that your family and your planning and your sort of advanced planning and estate planning and what you want in terms of your medical care is integrated with all of your providers. I think there are a couple of things that are always valuable to bring to any sort of these types of visits. You should know that each patient is individual, and depending on what's involved and how McCune-Albright's or fibrous dysplasia is affecting you, those are the things that you are looking for in terms of what types of treatments and types of teams are going to be there. Your physicians can help guide your management. You need to make sure that you do screening, and you should always try to keep on hand those treatment guidelines that Qasim Javid and a number of other people here have really worked on carefully. Make sure those treatment guidelines are shared with your physician, because those will actually give you and your team a lot of information about what the next steps are and what to look out for. When we talk about telehealth, this is sort of, obviously over the past couple of years with COVID, I think this has become much more common, but just a couple of tips about this. Try to make sure you do your visit in a quiet place. You should treat this like a doctor's visit. We want to give you the time that you deserve, but also, you want to be able to take in and accept and understand the issues that are being brought up and sort of the next steps for the management. Make sure your technology works. I think people have gotten much better with Zoom and different sort of types of access. And please don't do this while you're driving. We have had people do that. I will cancel your appointment if you do that, because I don't want you to do what this little red car has done at the end. But amazingly, people still try to do this. And I think that we want to give you the best of your care, so I think this is really important to make sure that we integrate that in. There are a couple of other things for optimizing your telehealth. You should realize that there are some things that are just best done in person. So, especially for our patient community with FD and MAS, we do sometimes need to see you. We need to figure out, where is the pain? How severe is the pain? We need to take a look at, we actually have to do a physical exam. Blood work, x-rays, we can't do those at home yet, but, those types of things, just be aware that this is part of the whole process. And if you have hearing loss, just be aware that telemedicine often does not work as well. Having a companion on the call to make sure you catch everything is great. The nice thing about telemedicine is that you can bring people in from all over the country or around the world, and so you should take advantage of that as a potential strategy. And gathering your information together and having your list of questions ready can be really helpful. One of the new things that we do have to talk about is being aware of laws governing interstate care. So unfortunately, many of the aspects that we as providers can do are governed by local laws regarding our medical licensing. So for example, it is very difficult for me to see a patient in another state. There are strategies for trying to help around that, but what you may need is to have a local physician to manage the orders and the prescriptions, and that a specialist from another state can actually provide your local physician with information about how to, what prescriptions to write and what sort of care that you should be having and what types of tests to do. So again, what I want to do is to really point out that the treatment guidelines are really the most important aspect to make sure that your provider and other people have access to. I usually recommend that you keep this as a link on your phone that you can just share, or you can text or something to a particular provider when you see them. It's really valuable to have. There's also the Fibrous Dysplasia McCune-Albright Syndrome Alliance. They have the provider directory. You can find a lot of information there. There's also now a series of videos as well as other sorts of resources, not only for you as a patient community, but also for your physicians that can be extremely valuable to access. And so again, I'm just going to say thank you to my team and also to everybody here for their participation. And I'm happy to take any questions. I think we have 20 minutes, I guess, for questions and answers. Yeah.
And with this patient, Doctor, have you seen correlation between this increase in symptoms in 40s and perimenopause?
So the question is, do you see changes in symptoms, particularly with perimenopause? That's a really interesting question. I have not seen like a very specific association, but it is entirely possible that that is the case. And actually, I don't know if Allison or Mike, have you seen correlations with changes in, I guess, bone pain, with perimenopause and menopause?
Some women report a lot of changes in pain with their menstrual cycles, but others don't.
Yeah.
Some report improvements in pain with pregnancy, some report worsening pain with pregnancy, and my sense is it's the same with perimenopause. Probably about a third of the time it gets better, third time it gets worse, and about a third of the time it stays the same.
It stays the same, yeah. So I don't think it's particularly, that's pretty much consistent with our experience too. So, yeah, thank you.
What is a normal IGF-1 level?
So the question is, what is a normal IGF-1 level? So unfortunately, that depends on the specific assay that they use. So you would actually, whoever they send it out to, you would have to ask them what the normal levels are. So I guess if there are no other questions, Dr. Collins and I will be around, as well as a number of other clinicians. So if there are any other questions, please feel free to find us. So thank you.